All right. So what I was told is that this is pretty informal and you guys are going to throw questions at me. Okay. So the hospice Medicare benefit is a benefit that is elected by the Medicare participant for end of life care for wherever they call home. And so to qualify for the benefit, there's two things that need to happen. So one is that a physician deems them to have a prognosis of 6 months or less, and that they elect the benefit so that they sign over and say that yes, they agree with this level of care. So those are the two things that have to be there, right? If the patient's not able to make decisions for themselves, then their surrogate decision maker can sign them on to services. So, so there's uh, basics that the Medicare hospice benefit is outlined to that it covers certain things, right? And then each agency can either stick with just the basics or go a little bit above and beyond. So without going into too much detail about what all those basics are, um, the thing that kind of sets SIVA Hospice a little bit apart from the other agencies is, as Dina had mentioned, I work full time for SIVA Hospice. I don't work anywhere else. And so then I am available to the clinicians, patients, and families um, almost 24/7, but truly during business hours, right? And then I also have part of my staff is nurse practitioners. I have two full-time nurse practitioners and several per diem nurse practitioners. I also have other physicians that work with us part-time. So we really take seriously the provider role of taking care of the patients and being able to support our clinicians in the field so that if there's anything that's going on with our patients and families, we're available right away and we can make adjustments right away. The other thing that we're able to do because I'm available is look at patients and kind of make a plan of care for patients that may be a little bit more complicated. So I like to meet with patients and families ahead of time and really set up a plan of care. If it's somebody that's needing tube feeds or TPN, has like drains, maybe has complicated wounds, all of those kind of things is something that I want to be involved in early so that we can really make sure, is this something that we can really help with, and is there something that we can provide or we can assist with and help take care of the patient?
That you benefit related to SIVA Hospice. And I know there are a couple of different hospices here. Do you all work similarly, or is that something you have a couple of medical directors, or do you just have?
We only have one,
Uh-huh.
and he's affiliated with Adventist Health. He does have his own practice. So
And
he
who is
goes
that?
out and sees Dr. Personius. So he goes out and sees patients in their home, not in the clinic setting, but in their home setting. But he's very reachable throughout the day as well.
Mhm.
If he's with a patient, yeah, we might have to wait for a minute before he can get back to us, but he's very quick
Awesome.
at getting back to us.
And Sheena?
Yeah, so actually Bristol does have three medical directors. They divide them up by territory, so each territory can have their own personal doctor that provides that care for each area.
Dr. Sharma, we also have Cindy from Golden San Andreas here joining us.
Golden San Andreas Care Center.
She's from the sniff world.
Yeah, we have patients at the other Goldens in like Stanislaus County and such. So I'm assuming you're related to that group.
All family.
Tell us about senior nutrition and how you handle that when somebody's on hospice. I know a few years ago over at one of the assisted living places that I worked at, it was a memory care unit. One of the residents died, and his family were really upset because the autopsy said he was dehydrated and malnourished. Well,
Mm.
the point of his dementia, I mean, you can't force
Right.
feed them.
No, and that's honestly going to be a lot of patients. That would be a finding on autopsy. So, one of the things is that no matter what disease process is going to be that terminal diagnosis and be ultimately the cause of death for that person, we all will end up on a kind of common final pathway where oral intake of food and liquids is going to decrease, right? And so then at some level, everybody that passes away is going to be somehow dehydrated and malnourished, right? And so then I that's awful and hurts my heart that, that they even had an autopsy done. And then to have those findings and then to kind of stick and, like focus on those findings is really heartbreaking for me.
Well, it's breaking for the staff as well, because they
Yeah.
really.
Yeah, I mean that's awful because that's expected, honestly. And so then that's one of the things that my clinicians, I'm really particular about education with the family to say that this is normal, though it can be distressing. One of the things that I always talk about is that as humans, culturally, no matter where you're from, food is love language, right? And so then that's one of the things, especially being, Indian, food is a big love language for us, right? And not to say that's across cultures, right? Something you're celebrating something, there's going to be food involved. You're grieving something, there's going to be food involved, right? And more than half of a budget for a party is going to be focused on food. So I do understand that it's something that we want to educate early when the patient and the family come on service. And I really want to focus on the quality and not the quantity. So though as the patient is walking this path, let's focus on the quality of food. So part of our plan of care is going to be to liberalize the diet as much as possible, depending on their diagnosis. So, they may not be eating a lot, but if ice cream is a big deal for them, then let them have the ice cream. I may have to adjust the insulin a little bit if they're diabetic, things like that, but that's doable, right? And so then let's, let them have what they want to have, and let's focus on the quality of the food, not the quantity of the food. If
Question.
that
regarding-
answers your question.
But it is really challenging,
Yeah.
considering, the delicate nature of the situation.
Mhm.
Oh, yeah. I took care of my friend's mom one night a week until she went to a home. And she, ended up eating fish sticks and ice cream, and badly should eat, that's what she
Yeah.
wanted. I figured she's 97 years old, and if that's all she's gonna eat, I'd rather have her eat fish sticks and ice cream than not eat.
Mhm.
So,
Yeah, sure. Yeah, that's
we
the
Yeah.
did.
way to do it.
I've always felt like that. I was like, and I sometimes probably would get in trouble because I would tell families like, if give them what they want. At this point, if you're on hospice, we don't know the length of their time. Give them what they want, whatever they want, as long as they don't choke.
Right.
Yeah.
Right. And that's the thing is that, we're so used to hearing from the specialists and the primary care doctors and things like that, that like we have to modify the diet for our diseases, right? So it's a big deal that like you have to watch your sugar. Well, but why do we have to watch our sugar? It's because we're trying to prevent end organ damage from that disease process. Well, once you're on hospice, that's already happened, right? Or you don't have enough time to like get to that point. So I don't care anymore, right? It's really of like, what do we want to do to promote quality of life at this point? I'm not looking at, I obviously I don't want you to go into DKA, but the thing is that, I'm not looking at that tight control, because dropping your sugar is more dangerous than having it a little bit higher. So though people are kind of like have it stuck in their head that their fasting blood sugar has to be 100, their fasting blood sugar has to be 100. And now I'm trying to rewire that and say your fasting blood sugar can be 200. I'm okay with that, right? Because we're looking at different endpoints now.
Right.
As long as you document that you went over the risk versus benefit with them. If they want a cheeseburger, don't have a cheeseburger.
Yeah, exactly, exactly.
How do you handle situations that become difficult with the family? We were called in, this was several years ago, but we were called in to assist with a hospice patient. And the husband was not wanting to say goodbye, basically. That's the
Okay.
end thing. And then they allowed him to have, I guess, access. They provided a machine to suction out the, all the things that
Yeah.
happen. And they wanted us to assist with that suctioning. Her heart
Yeah.
must have been great because she wasn't passing and still doing morphine for pain and things like that. But he just wanted to keep her, going alive. I guess maybe not so much morphine like to that point, but enough to keep her from too much pain. When is it time for when the director or the doctor steps in and says, do we just discuss the length of how hospice is going?
Yeah. So in your scenario, I would have stepped in, or one of my team members would have stepped in before we got to that point.
Oh, okay.
So anybody asking for a suction machine, that's not an automatic. Like, I want to know what the situation is, and I want to know, are they going to be reliable and understand when to suction and things like that, right? So one of the things that I am particularly advocate for is caregivers or family need to be family. And though I know in the hospice realm, because of staffing and, how it's written and all this kind of stuff, we can't necessarily be the caregivers 24/7.
Right.
And family does have to kind of take on some of that role. I'm really particular about trying to set a line in the sand about where that is, right?
Very good.
Because I don't want the family to be 100% without understanding. So one of the things I tell my clinicians, my nurses all the time is, how many years of school did you go to be able to assess a patient to determine if they needed morphine or not, to be able to assess a patient to know that they're in pain or that they have shortness of breath. You went through all of this training, and now you expect the family to be able to do that after you've educated them for 15 minutes.
Yeah, good point.
And that is not fair. And honestly, if I wrote the Medicare hospice benefit, it would be way different.
True.
But so I always say that we need to do education, like, constantly, right? And find out, we need to have a finger on that pulse of, where is that family? How much do they understand? And and this should have been addressed way earlier with this particular husband, right? Is that, what is his expectation and where do we think this is going? And this would have been like probably at the time of admission to start and to say, we need to have like maybe weekly check-ins for a little while to really say, what's going on? Let's help you understand what the expectation is. Where are you coming from? And this is again where I would be leaning heavily on my social workers and chaplains to really help with that non-medical, that spiritual side of it. I mean, I imagine they've probably been married for 50 plus years. They've probably been together forever. He's been taking care of her for a long time. There's so many different levels that are going into this. It's not just the fact that she's passing away, but what is he grieving? And what is he not able to let go of? So we need to look at it as an entire picture. It's not just that medicine part of it.
Yep. A lot of dynamics to hospice.
Oh, yes.
Yeah.
It's not just patient-centered, that's what the benefit is there for. So it's the whole family and what they're going through. So that's why psychosocial is a very important part of hospice.
It really is.
It really is. It really
Yeah.
is. And sometimes we get families onto service and they have a stigma against the pain medicine. So they think that, they have a different idea about giving morphine or giving pain meds. What about that, Dr. Sharma? How do you deal with educating families against the pain medicine? Because of reasons of perhaps they're going to be addicted or they don't feel like their loved one needs the
Right.
So,
Or it's gonna kill them.
Right.
Right. I mean, and unfortunately that comes up a lot, right? The whole opioid crisis and how the pendulum swang so far to the other side of like everybody gets opioids and now like nobody gets opioids, right? And it's one of those things again, is that really getting down to what is the fear or concern and then being able to address that specifically, right? Because I mean, I can come up with an elevator speech about, you're not going to get addicted. These are the studies that show this, that, and the other thing. But if the person if that's not going to really address what specifically their fear is, it doesn't matter. It's going to go right over their head. And so then we really want to find out what is the fear and let's address that. And again, multidisciplinary, right? Is it because you had another loved one that was on hospice services in the past and they got that dose of morphine and passed away? Is it because you have, a substance abuse history in the family? What is it that is causing that concern? And then let's address that. And the next step would be multiple times we've had my nurses actually administer that first dose and stay with the patient and the family for an hour, hour and a half, 2 hours, whatever it needs to be, to say, look, I'm going to give you a baby dose and let's see, does it help with your symptoms? Let's look for the side effects. I'm here. I'm staying here. I'm going to be available. I'm going to be watching and I'm going to see if anything happens. I have the doctor on speed dial. We can deal with it if something happens. And sometimes that helps. I had a patient actually down south, really bad COPD, and was just so scared of the morphine, so scared that he wasn't going to be awake anymore, right? And he really wanted to be awake. It was just him and his wife. They'd been together forever. There's also that fear of leaving her alone. There's so many different dynamics going on. And it was just, like every time I would see him, I would say, both of us are here. Me and the nurse are here. Let's try a little bit of morphine. Let's try a little. And he just wasn't ready. And then finally he was. And so then, we gave him that dose of morphine and it helped with the breathlessness so much. And he was able to relax and he was able to actually talk with his wife and have a meaningful, moment with her, that then he said, yes, I want to continue and I want to take the medication because now I see that I'm going to be able to have these meaningful moments with her, where I was so focused on my breathlessness before that I didn't have any energy left. And it just takes time sometimes.
yeah, definitely case by case as well. Yep.
Yeah.
Yeah,
Thank
for
you.
sure.
Well, and I think that diving into why somebody feels the way they do is really important because you might have a spouse that years ago let their wife's favorite cat die and you still feel guilty about it. So now you're gonna try to keep her alive as long as you can because you still
Yeah.
feel guilty about the cat.
Always
Oh, I mean, it could be something as bizarre as that.
Yeah. You never know. I mean, we come into the picture so late
Mhm.
in the story. And it's really important to know what that story was before we got there. Everybody's situation is different. Everybody has different experiences, and that colors how they make decisions. And it's hard, you can't come at everybody with like a set script. It really needs to be personalized for each person in each scenario.
Yeah, very good. Yep. Any other questions or concerns or scenarios the group would like to discuss?
I'm curious about family dynamics. I'm sure you've run into situations where,
It's a big one.
half the siblings want one thing, half the siblings want another thing, and
Yeah.
the spouse wants a third thing. How do you
Yeah.
handle?
Again, it's a lot of talking. And it's a lot of trying to get people to look at not what they want to get out of the situation. Because a lot of that can happen, right? Is that they're again colored by different things. Maybe there's guilt that they weren't around enough. Maybe there's animosity or anger because of some past situation that has happened. Every family has dynamics. So, I just, no matter what, there's some level of dynamic everywhere, right? Some of them are more complicated than the others. And it's just, again, talking and revisiting over and over again that what we need to focus on is the patient. And what does the patient need and what would the patient want if they're able to speak for themselves, right? And trying to bring it back to that. It doesn't always work. And in the short amount of time that we're with a family, we're not, marriage counselors, and we're not going to be able to fix all of that. Our hope is that we can at least bring them together for this particular situation. And if it doesn't work out, then we may have to be really specific and say, okay, you know what, this is not, maybe we need to just appoint the one person that's going to make decisions. And then we can continue to help during the bereavement process to try to help reconcile that grief. But again, the patient is our main focus. And so we just have to work around that. It's a lot of talking, and we try to just get to that root cause and just say, this is what we need to focus on. And if you can put everything aside and say we need to focus on mom or dad or whoever it is, that'll be great. And then we can try to figure out the rest of it after.
I think you touched on something important, and that is the family is already grieving,
Mhm.
going through this process and they're grieving. And I think it's important to keep that in mind because it can, well, in my case anyway, I think it tempers how judgmental I get about,
Yeah.
you're not doing this for them, darn it.
Yeah.
Yeah, so
Yeah.
what about the spiritual needs of the person?
My chaplain group is amazing. And one of the things, because when you come onto hospice services, I always, again, try to remind my team that it's a whirlwind when you come onto hospice services. And all of a sudden there's all these people that want to come to the house. There's all these people that want to come meet you, and everybody's going to ask you the story all over again, right? And it's like you have to repeat yourself, and there's so many things going on. And so then decent percentage of people are going to say, you know what, I don't need social work. I don't need spiritual care. Like, all I need is the medical aspect of it, right? And they may initially say, no, I don't want to meet with any other people. We can be a little bit sneaky. So we may let them, do this for a few weeks and just have the nurses go out. But then maybe the chaplain needs to drop off some supplies, right? So it's like, oh, you need some checks. You know what? Our chaplain's driving right by your house. They're gonna kind of drop it off and kind of get them to sneak in there a little bit and just introduce themselves and say, hey, if and it works because a lot of times it's like, oh, come on in, let's talk for a minute. And then it's just that, developing that rapport to be able to have the ability to just have that conversation. And my team's so good at it that most of them have been in hospice for a really long time, and they know how to kind of get around those kind of the stigma again of like a spiritual care counselor. Well, what does that mean? Right? Are you going to convert me to some religion, or like what the heck is going on? And it's just, to help ease into that.
Well, can you talk about med management a little bit? And so let's say I have cancer, I have diabetes, and oh, I don't know, I have high blood pressure too. So now that I'm on hospice, I'm not getting the cancer care anymore, but what about the blood pressure meds and the diabetes meds, stuff like that? What happens with that?
Yeah, so depending on where you are in the disease process, we're going to be continuing and modifying those medications. So I'm not in the business of hastening anybody's death, right? So we're going to still be treating all of those things. I may be switching stuff around. And part of that is because some things based on age, kidney function, things like that or may not be safe, right, anymore for you. I'm a big advocate for insulin. I can adjust that very quickly. And I can, and I can control the sugars to a point that I want with the insulin versus some of the oral medications, especially with kidney functions changing as you're on service with us. is that those oral medications can hang around for a long time and drop the blood sugar for a long time. The nurses will be coming out and checking blood pressure almost every visit, and I can adjust those medications as needed depending on what the trends are. So honestly, coming onto hospice services is the best level of care that you'll ever have, because the nurse is coming out at least a couple of times a week and checking everything, and I can adjust stuff a couple of times a week versus you like waiting for 6 weeks to go see the doctor. So definitely there's not that, oh, we're going to just discontinue everything and we're only going to give you morphine and Ativan. That's not the deal. Right now, everybody has allergies, the beautiful almond blossoms, right? And all of my lung patients are having exacerbations. And so we're treating all of that. I have Z-Paks galore going around everywhere for all of the COPD patients right now, right? And steroids and breathing treatments and everything to make sure everybody stays comfortable through the season. So it's definitely something that we look at. I'm going to adjust a lot of things. And we're going to keep an eye on everything and make sure that it's appropriate for wherever you are in your disease process.
Okay, and then it's my understanding, correct me if I'm wrong, that part of the hospice service is also providing those drugs, so I'm no longer getting my Part D insurance. It's coming actually out of my Medicare benefit. Is that correct?
So part of the Part D is still going to be around. There's going to be some things that are not covered by hospice. Virtually everything will be covered by hospice, but there are a few little things that are not covered by hospice, and that would go to Part D. I, in general, am not going to necessarily be covering a lot of supplements. And that's just because by the time you're coming to me, the supplements are not necessarily going to help. That doesn't mean that you have to stop them. It just means that it's not going to be part of the hospice plan of care. So if you want those supplements, and it depends again on which supplements, I'm just kind of blanket statement saying things, but we're going to look at all of the different scenarios, right? And see what it is. I may be looking at, just like any other company, any other insurance, we have a formulary. And so then there's going to be things that I'm going to look at. I'm going to say, you know what, this particular insulin is the one that's on my formulary. If you want to stay with a different insulin, though, I'm going to explain to you, it's all the same, it's bioequivalent and all that kind of stuff. If you're still like, nope, I like this particular one, that can go to Part D. Now, I can't guarantee that Part D is going to cover it, but it can go to Part D. Yeah.
Thank you.
Any other areas, topics you'd all like to talk about?
I have one last one, and that's aspirin. I read years ago that as we age, our stomach lining gets thinner. And seniors need to be careful about how much aspirin they take, because they can end up with bleeding ulcers, I think.
Yeah.
From the acid.
So again, aspirin is a though pretty ubiquitous and an over-the-counter medication, can have a lot of risks, just like you mentioned, right? The other thing that I always look at and ask is that as patients are with me, they're getting weaker. And I have a lot of patients that fall, either because they don't remember that they're weak and they can't, walk, or they're stubborn as hell and they're gonna walk no matter what, right? So kind of both sides of that. And so then that's the other thing that I'm going to be thinking about, is that, does this patient really need the aspirin? We have to weigh the risks and the benefits, right? And each patient is going to be very, very particular. If you have a really high risk of stroke, if there's a lot of things going on, and I really feel like it's important for you to have the aspirin, then I'm going to be also having you be on Prilosec or something like that to help protect your stomach lining, to give you a little bit of that extra boost so that we can prevent those bleeds. But also, if you already have a history of bleeding, or you're falling a lot, you're starting to get some wounds, or you keep getting skin tears, things like that, then we're going to have to say, you know what, maybe it's not worth the aspirin anymore. But that's, again, a discussion that has to happen. And I want everybody, I want the patient to be involved as much as possible. This is still their care. Though I can make recommendations, they still need to understand and make the decision of, like, do they agree with me or not, right? Just like with any other medication, when we talk about the pain medications, when we talk about the different things, I can say this is what you need and this is what I think is going to help you, but they may not agree with me.
And that's the bottom line, it's choice,
Yes.
individual choice.
Yeah, and part of that choice is again informed consent. And I'm a big stickler for that. Is that I'm not going to tell you that I want to discontinue or start a medication without explaining why. Because I want you to understand my thought process and give you the opportunity to question it. And then we can move forward.
That's all I have.
Very
Thank
good
you so much,
question.
Dr. Sharma.
Thank you.
Thank you for your time and your guidance and your knowledge. So we all appreciate that so much. It was very kind of you to come on and take some time to introduce you to the group and introduce the group to you. And again, Dr. Sharma with SIVA Hospice.
Thank you for having me,
Oh,
ladies. It was great
of
to meet
course.
you.